TopMedTalk.
All right, well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are coming to you from the European Anesthesiology Congress, Euro Anesthesia 2019 in Vienna. I'm joined today by Editor-in-Chief, Monty Mythen.
Day's going well, Desiree.
So we were able to catch an old friend. You want to introduce
an old colleague as well. We've got a bit of history to share.
Oh, you do?
Professor T.J. Gann, who's now at Stoney Brook.
That's correct.
Long Island?
In Long Island, indeed.
It's about Greater New York, as I think of it. Long Island, which I visited, very lovely place.
It is beautiful.
And in the past, our paths have crossed.
Many times.
In the United Kingdom, at the old Middlesex Hospital.
Exactly.
Various different places en route, and then we were at Duke together for a while.
Indeed.
We could talk about so many wonderful things.
I want
us to talk about PONV. I just want a quick update.
Oh, yes, TJ.
Is there anything new in PONV?
Come on, tell us.
There is indeed. Funny you mentioned that because we just had our...
We should say what PONV is, by the way.
Oh,
Desiree.
I'm sorry. Post-op nausea and vomiting. Yes.
So the answer is yes, there is. We, in fact... so just give you a bit of background. We had our third post-operative nausea and vomiting consensus guidelines published in 2014.
Yep.
And now it's 2019, so a number of years has passed. So recently we had a regroup of a group of experts in post-op nausea and vomiting and had an update on the consensus guidelines. And a meeting we just had a few weeks ago, and so now we are in the middle of putting the information together. And there are some new strategies, management strategies, and also there's a new drug on the post-operative nausea and vomiting front.
Okay. How does it work? Where is it?
Yeah, tell us more about it.
The new drug is called Amisulpride. Now, Amisulpride is an interesting drug because it's a dopamine antagonist.
Right.
Now, we are familiar with droperidol, which is a dopamine antagonist. Now, droperidol was a very popular antiemetic until when the FDA put a black box warning back in 2001. And because of the concern about QT prolongation and torsade de pointes.
Dangerous heart arrhythmias.
Correct. And so as a result of that, the use of droperidol literally dropped to almost nothing.
Yeah.
And then since then, we couldn't get droperidol in most of the parts of the U.S. And so this drug is actually working through the same mechanism. It's a dopamine D2, D3 antagonist. So it does have a very similar efficacy like droperidol, but the advantage is that in the clinical dose that we use, it doesn't really have any increased risk in QT prolongation. So it is a bit similar to giving droperidol without concern about the QT prolongation. So that drug is currently undergoing FDA approval, and again we shall see where that leads us.
And any other novel strategies outside of the box thinking on PONV? Any other?
Yes, I think the other thing is that we all know that combination antiemetics work better than the single agent. But interestingly, recent surveys shown that many of our patients still do not get optimal combination therapy. As a result, the incidence of PONV is still unusually high and really should not be as high as what we see today.
Even after some of the quality measures that have been put out with the MIPS and all those things that we have to do, has that made a difference?
Yeah, Desiree, it's interesting you say that because that you would have thought that, with that MIPS quality metrics, the clinician will then administer the appropriate number of antiemetics. Yeah. And I can tell you that, based on the survey that I've seen, in a hospital, for example, is only about 60% of anesthesiologists actually follow what the MIPS guidelines suggest to follow. So in other words, in a high-risk patient, that you've got to give at least 2 or more antiemetic as prophylaxis.
And you have to check the box that says you did it.
The box. But that means that this hospital do not actually get reimbursement. In fact, they get a penalty from their Medicare patients.
Yeah, that's crazy.
We'll move on from this in a second, but we did some research in the past, and a recurring theme was that if we looked after the patient's circulation and their volume status correctly, they seem to throw up less often. And mechanistically, that makes good sense. But that doesn't seem to sort of necessarily always wander into the guidelines. It seems to be all about the drugs to stop the sickness, as
in
opposed
fact,
to... Is it in there?
It is actually in there. One of it is adequate hydration. Now, fluid is an interesting thing. So it's really almost as like a Goldilocks situation, right? You want to be not too little, which increases PONV because of potential gut ischemia and under perfusion. On the other hand, you don't want to give too much fluid, which can potentially cause bowel edema. So there is that happy medium sweet spot where you need to hydrate the patients if they are inadequately hydrated, and not to give too much, especially crystalloid, which can cause bowel edema.
So it's still there as a kind of look after the fluid management, keep it perfused.
Yes.
Because there's an excellent letter by Gann and Mythen, or Mythen and Gann, in the Lancet about 55 years ago.
Yes.
that draws attention to that. Whew. So someone was listening.
Good.
So...
Thank you so much for finally joining us, TJ.
Desiree, it's always good to be here. And Monty, it's always good to chat with you.
It's good to see you. Thank you.
Okay, thank you very much.
TopMedTalk.
Desiree Chappell here. Just a quick reminder, subscribe to TopMedTalk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at TopMedTalk.com. That's www.topmedtalk.com.